Welcome to our deep dive. Whether you are, prepping for a medical consultation, maybe exploring options for your own health, or you just love a really good deep dive into the fascinating mechanics of the human body, you're definitely in the right place. Today, we have a highly specific, but honestly incredibly vital mission. We are answering one very direct question. Do I need a pelvic exam before vaginal tightening?
Yeah, and to give you a really comprehensive answer, we pulled together a pretty massive stack of source material for this one. We are looking at clinical consensus statements from the American Urogynecologic Society. They're often referred to as AUGS and direct safety communications from the FDA.
Right, the heavy hitters.
Exactly. And we also brought in detailed pelvic examination guidelines from medical education powerhouses like Lecturio and the Royal College of Nursing. Plus, we're cross-referencing all of that medical literature with the actual real-world pre-treatment protocols from clinics that are using popular laser and radiofrequency devices, so things like Thermova, Vemilift, and Fotona.
Well, the short answer to our core question today is a resounding yes. You absolutely need one. But the hook here isn't just the yes, right? It's the biological reality behind the yes.
Right, because it's not just bureaucratic red tape.
No, not at all. Understanding why a doctor needs to map out your pelvic floor before applying a laser reveals some truly wild things about how our bodies heal, how our nervous system reacts to thermal energy, and why treating the surface of a problem is sometimes, frankly, the most dangerous thing you can do.
Yeah, we can start by looking at the sheer explosion of what the medical field calls EBDs, or energy-based devices. These are your fractional CO2 lasers and radiofrequency wands.
Right, they're everywhere now.
They really are. And for a long time, the aesthetic industry treated these devices as a magical cure-all for, basically any vaginal complaint. They marketed them as a quick, non-surgical way to rejuvenate tissue. And the premise sounds really simple, right? You apply heat to the mucosal walls of the vagina to stimulate collagen production.
But the reality of what is happening at a cellular level is much more intense than just, warming things up like a heating pad.
Oh, absolutely.
These lasers are creating controlled microinjuries. They are intentionally damaging the tissue to trigger the body's natural wound healing cascade.
Exactly. It's thermal trauma.
Yeah, and when you cause that thermal injury, fibroblasts, which are the cells responsible for making connective tissue, they rush to the area and start laying down new collagen. It's essentially tricking the body into repairing tissue that has thinned out due to age or childbirth or hormonal changes.
And because you are deliberately inflicting microscopic wounds on really delicate internal tissue, the regulatory bodies had to step in and build some serious guardrails. I mean, the AUGS consensus statement is completely unambiguous on this point.
What do they actually mandate?
They say any patient seeking EBD therapy must have a focused gynecologic examination within 1 year prior to the treatment. And honestly, many of the actual clinics are far stricter than the national baseline.
Oh, really? Like, how strict?
Well, if you look at the protocols for a device like Femolift, or the guidelines from providers like Illuma Laser, they demand a normal pelvic exam within the last 6 months and a negative pap smear within 1 to 2 years, depending on your regional health standards.
Which makes sense because the FDA actually forced the industry's hand on this. Back in 2018, they issued a major safety communication warning against using these energy-based devices for vaginal rejuvenation without established safety protocols.
Yeah, and they weren't just being overly cautious bureaucrats there.
No, they were tracking severe adverse events. Patients were suffering from devastating vaginal burns, permanent scarring, and chronic debilitating pain. Dr. Vivek Nama, who is a consultant gynecologist at the Women's Health Clinic, summarized the medical community's response perfectly in our sources.
Right. He stated that a physical examination and screening for abnormalities are essential prerequisites to treatment.
Because it establishes your baseline health. I mean, it's like getting a structural foundation inspection before remodeling a house. You don't want to put expensive new wallpaper over a wall that is structurally compromised.
That is a great analogy. Applying a high-powered thermal laser to an area of the body without fully understanding the underlying biological ecosystem is just a recipe for disaster.
Yeah.
The exam acts as a diagnostic filter. It ensures that the specific biological mechanism of the laser will actually help your specific symptoms rather than amplifying some hidden problem.
Right. So if you walk into a med spa or a clinic and the provider offers to waive the pelvic exam to save time, or they just suggest you jump right onto the table for your first laser session, you should view that as a glaring neon warning sign.
Oh, massive red flag.
They are willing to operate blindly on your internal organs. So let's explore what a responsible physician is actually hunching for when they do this assessment. If the goal is to filter out bad candidates, what biological threats disqualify someone from getting laser tightening?
Well, the first major category of disqualifiers involves active infections. A clinical protocol will almost always require a visual assessment and a urine culture.
To check for what, specifically?
They want to ensure the environment is entirely clear of things like bacterial vaginosis, severe candidiasis, which is a yeast infection, and viral outbreaks, so active herpes simplex or HPV lesions.
And applying that wound healing cascade we discussed earlier, the danger here is immense. I mean, if the tissue is already inflamed and battling a viral infection like herpes, adding ablative trauma, meaning a laser that literally vaporizes the top layer of cells that would strip away the local immune defense.
Exactly. You are opening up fresh microscopic wounds in an area that is already crawling with active pathogens.
So it would just spread the virus deeper into the tissue and invite severe secondary bacterial infections.
Yeah, the heat basically acts as an accelerant. The area is already suffering from an inflammatory immune response. Adding a thermal burn to that environment does not stimulate healthy collagen. It stimulates rampant inflammation and potentially irreversible scarring.
That sounds horrific. Now, another condition the exam screens for is something that actually confuses a lot of patients, and I really want to dig into this. The clinics explicitly screen for pelvic organ prolapse, or POP.
Right, this is a huge one.
The Thummy-lifted Termiva protocols clearly state that their lasers cannot treat severe apical or complete uterine prolapse. So usually that's categorized as stage 2 or higher. Now, based on the medical literature, a prolapse literally causes a feeling of looseness, heaviness, and a lack of friction in the vagina.
Yes, that's exactly what the patient feels.
So if a patient is coming in to fix a feeling of looseness, turning them away seems totally counterintuitive. Isn't tightening the whole point of the device?
I know, it sounds backwards.
Yeah.
But the confusion stems from treating all vaginal symptoms as if they have the exact same root cause. We have to separate superficial tissue laxity from deep structural dissent.
Okay, break that down for us.
So tissue laxity involves the mucosal walls themselves. After childbirth, or, as estrogen drops during menopause, the mucosal lining loses its elasticity, becomes physically thinner and looser. The laser is phenomenal at treating that specific layer by shrinking the existing collagen and prompting new growth to restore surface tone.
So if the mucosal lining is the asphalt on a bridge, the laser is doing a great job repaving the road to make it firm and smooth again.
That analogy captures the mechanics perfectly, yes. But pelvic organ prolapse is a failure of the suspension bridge itself.
Ah, I see.
The deep fascial tissues and the strong ligaments like the uterosacral ligaments that hold the bladder, the uterus, and the rectum up inside the pelvic cavity, they have snapped or stretched beyond their elastic limit.
Right, so if a patient's bladder has physically fallen backward into the vaginal canal, creating a bulge known as a cystocele, shrinking the surface mucosa by a few millimeters with a laser is not going to hoist a heavy fluid-filled organ back up into the pelvis.
Exactly. Repaving the asphalt does absolutely nothing if the steel cables holding the bridge up have completely snapped. You need a structural fix, not surface resurfacing.
Right, so the diagnostic exam distinguishes between the two. A provider has to know if they are dealing with tired mucosal tissue or a collapsed anatomical structure because the laser only fixes the former.
Spot on. Now, the next major disqualifier on the pre-treatment checklist is vaginismus. This involves the provider checking the pelvic floor for involuntary muscle spasms.
Right, and if a patient experiences painful spasmodic contractions that make penetration incredibly difficult, applying a thermal laser seems like throwing gasoline on a neurological fire.
It absolutely is. Vaginismus is fundamentally a neurological and muscular pain loop. The brain perceives vaginal penetration as a severe threat, and it signals the pelvic floor muscles to aggressively guard the area by clenching.
And the laser's mechanism of action involves heat and microinjuries.
Exactly. So if you introduce painful stimuli and heat into a nervous system that is already hyperreactive, the brain interprets that thermal energy as a massive attack. It will lock those muscles down even harder, reinforcing the pain loop and making the vaginismus significantly worse.
Wow. Okay, so the final major disqualifier brings us back to the cellular level. Cancer. This is why the AUGS guidelines and aesthetic clinics mandate a recent negative pap smear, right?
The provider has to guarantee there are no precancerous cells, cervical cancer, or other gynecological malignancies hiding in the tissue.
And why is that so critical with these specific devices?
Well, the mechanism of energy-based devices makes this an absolute necessity. We talked about the wound healing cascade earlier. Part of that cascade is a process called angiogenesis.
Angiogenesis, which is the formation of new blood vessels, right?
Yes. The laser stimulates the release of growth factors that tell the body to build new capillaries to feed the repairing tissue.
Oh.
But a malignant tumor's greatest requirement for survival and expansion is a robust blood supply.
Oh, wow.
Yeah. Stimulating cellular turnover and triggering massive blood vessel growth in an area harboring precancerous cells is biologically catastrophic. It is providing the exact fuel a malignancy needs to thrive.
So understanding these massive risks, rampant infection, untreated organ collapse, neurological pain loops, and literally feeding malignancies that completely reframes the pelvic exam. It isn't a bureaucratic hurdle at all.
No, it is a vital, life-saving diagnostic.
But, for the listener sitting at home, understanding the necessity of the exam doesn't automatically erase the anxiety of actually going through it. The clinical guidelines from Lecturio and the Royal College of Nursing break the physical examination down into 3 distinct phases. And I think walking through the causality of these steps can really demystify the experience.
Yeah, that's a great idea. The process moves systematically from the outside in. So phase 1 is the visual inspection of the external genitalia. Before any instruments are introduced, the provider is observing the external ecosystem for those obvious red flags we discussed.
Right, the viral lesions, abnormal discharge pointing to a bacterial issue, or warts.
Exactly. And they're also highly attuned to dermatological conditions like lichen sclerosis.
And for our listeners unfamiliar with lichen sclerosis, it's an autoimmune condition that aggressively attacks the epithelium, which is the very top layer of the skin cells. It causes the tissue to become incredibly thin, white, and prone to tearing.
Right. And while there are some emerging studies looking at specialized laser protocols to treat lichen sclerosis, a standard cosmetic tightening session would just blast away an already fragile, compromised layer of skin without addressing the autoimmune root cause.
It would be a nightmare.
Truly. So once the external ecosystem is cleared, the provider must evaluate the internal mucosal lining and the cervix, which brings us to phase 2. The speculum exam.
Okay, so this is when they insert the speculum to gently open the vaginal canal and visually inspect the internal walls.
Yes. They're looking at the health of the mucosa. Healthy vaginal tissue has rugae, which are natural accordion-like folds that allow the canal to stretch and expand. If the tissue looks pale, flat, and lacks those rugae, it indicates severe atrophy.
And this is also the exact moment they grab the sample for the pap smear to screen for those precancerous cells or take swabs to culture for yeast or bacterial vaginosis.
Exactly. Everything happens in that one step. Then phase 3 moves past the surface tissue and evaluates the deeper structural integrity of the pelvis. This is the bimanual exam.
So the provider places 1 or 2 lubricated fingers inside the vagina and their other hand on the patient's lower abdomen.
Right. By pressing down from the outside and feeling from the inside, they can assess the size, shape, mobility, and tenderness of the uterus and the ovaries.
And to diagnose the structural prolapse we talked about earlier, the suspension bridge failing the sources mentioned a specific technique called the Valsalva maneuver. The provider will ask you to bear down, similar to the pressure you exert during a bowel movement, or they will ask you to cough.
Yeah, the Valsalva maneuver drastically increases intra-abdominal pressure. When the patient bears down, that pressure pushes all the internal organs downward. The examiner can physically feel and see if the ligaments have failed.
So they can observe if the bladder is bulging down into the anterior wall, forming that cystosol, or if the rectum is pushing into the posterior wall, forming a rectocele.
Exactly. And having the patient cough also reveals if sudden spikes in pressure cause urinary leakage, which provides a definitive diagnosis for stress urinary incontinence.
Putting myself in the shoes of a listener who is seeking out a laser treatment, specifically because they suffer from severe vaginal dryness or dyspareunia, which is severe pain during sex, this entire 3-phase process sounds incredibly daunting.
I completely understand that.
Inserting plastic or metal instruments and performing manual palpations on tissue that is already highly sensitive and painful seems like an immense barrier to care.
It is a very valid concern. But the medical community acknowledges that anxiety. The guidelines, particularly from the Royal College of Nursing, emphasize that patient comfort and consent are the foundational pillars of the exam.
So how do they manage that discomfort?
A skilled provider utilizes several specific techniques. They will select a much smaller, narrower pediatric speculum for patients experiencing severe atrophy or pain. And they also rely heavily on generous amounts of water-soluble lubrication.
Wait, there used to be a widespread belief that using too much lubricant would ruin the cellular sample for a pap smear, right?
Hmm.
Leading doctors to perform the exam dry, which was agonizing for the patient.
Yes, that was a huge issue in the past. But fortunately, modern liquid-based cytology has completely solved that issue. Water-soluble lubricants do not compromise the modern cellular analysis used in pathology labs today. Providers can, and absolutely should, use adequate lubrication.
That is a huge relief to hear.
Yeah, it's a game changer. And beyond the physical tools, the guidelines stress psychological comfort. The provider must narrate every step before it happens, so there are no surprises. They also establish a clear physical signal, like the patient raising their hand, that guarantees the exam will halt immediately.
So the patient retains absolute control over the pacing and continuation of the assessment.
Exactly. They are in the driver's seat.
Okay, let's follow the diagnostic path to its conclusion. The patient gets through the exam, the provider analyzes the findings, and they arrive at a diagnostic crossroads. Suppose the exam reveals that, based on the biological realities of the tissue or the structure, the patient is not a candidate for a fractional CO2 laser or a radiofrequency wand.
Well, being disqualified from the laser does not mean they are disqualified from finding relief. It simply means the diagnostic filter worked and they need a different biological tool.
Because the value of the exam is that it points the physician toward the correct medical intervention.
Exactly. For instance, if the bimanual exam reveals that the issue isn't thinning mucosal tissue, but rather a profound weakness in the deeper pelvic floor musculature, applying surface heat is useless.
Right. So the appropriate path is referring the patient to a pelvic floor physical therapist. Physical therapy is the gold standard for actively rebuilding muscular tone and restoring functional strength to the pelvic bowl.
Yeah, and if the Valsalva maneuver reveals the suspension bridge has collapsed, meaning there is a significant cystocele or rectocele, the patient is diverted away from the aesthetic clinic and towards surgical consultation.
Because procedures like an anterior or posterior colporrhaphy are required to physically suture, lift, and reinforce the rectovaginal septum and reattach those failed ligaments.
Exactly. And in cases where the speculum exam reveals severe genitourinary syndrome of menopause, often referred to as GSM, where the root cause is a systemic lack of estrogen causing the tissue to thin and dry out, thermal trauma isn't the first line of defense.
Right, the provider will likely prescribe localized vaginal estrogen or permethrin creams. By introducing hormones directly to the estrogen receptors in the vaginal mucosa, the tissue rebuilds itself from the inside out. It restores moisture and elasticity.
And this approach treats the hormonal root cause,
hmm
and it happens to be a fraction of the cost of undergoing multiple expensive cosmetic laser sessions.
So the pelvic exam acts as a brilliant triage system. It protects you from wasting your time, your emotional energy, and thousands of dollars out of pocket on a cosmetic procedure that your anatomy doesn't actually need, and in some cases cannot safely handle.
It diverts you away from ineffective surface treatments.
Right, and points you directly toward the physical therapist, the surgeon, or the pharmacy that holds the actual solution to your specific symptoms.
It forces the medical industry to prioritize individual pathology over the simple transactional sale of a laser package. It grounds aesthetic desires in biological reality.
So, to synthesize everything we've uncovered in the sources today, do you need a pelvic exam before vaginal tightening? Yes, without question.
Absolutely.
It prevents a provider from triggering an aggressive infection on compromised tissue. It differentiates between superficial tissue laxity and deep structural prolapse, ensuring you don't use a surface laser to treat a collapsed ligament.
Right. It prevents the application of thermal energy to hyperreactive spasming muscles. And it screens for precancerous cells to guarantee you aren't stimulating a lethal blood supply to a malignancy.
It is the ultimate safeguard, ensuring that energy-based devices serve to heal you rather than harm you.
The requirement demands that providers respect the complexity of the female anatomy before attempting to alter it.
It really does, and it brings us to a really compelling thought to leave you with today. Throughout this exploration, we've constantly bumped up against the line separating aesthetic, cosmetic desires like seeking tightness or youthful appearance and functional medical needs, things like treating incontinence, prolapse, or painful intercourse.
Yeah, and historically, the medical field has heavily compartmentalized these two areas.
But as technology like energy-based devices continues to evolve, that line is rapidly disappearing.
Because the physiological reality is that how a tissue looks, how it feels, and how it biologically functions are deeply intertwined.
Exactly. So what if the future of women's health abandons that separation entirely? Instead of treating cosmetic issues in a med spa and functional issues in a sterile clinic, we could start viewing the pelvic floor as a unified, integrated ecosystem.
A paradigm where experiencing physical pleasure, feeling confident in your body, and functioning flawlessly on a mechanical level are not seen as separate categories.
Right, but as equally vital, interconnected measures of overall human health, moving toward a holistic model where aesthetics and function are treated as two sides of the same biological coin would revolutionize patient care and lead to far more comprehensive, durable outcomes.
It is a massive shift in perspective and one that is well worth pondering.
It really is. Thank you for joining us on this deep dive into the clinical realities of pelvic health. Keep exploring the science behind your health. Never stop asking your providers the hard questions. And remember, before you try to remodel the surface, always demand a thorough inspection of the foundation.